Welcome back to the second installment of the conceptualization lectures for the week. Today, I'm going to talk about the biomedical model just a little bit, but really the star of the show is the biopsychosocial model. I'm going to move my window down here so you can see it. When we think about aging sexuality and a model that really captures or is inclusive of sex across the lifespan, the biopsychosocial model is the way to go. It gets the gold star. And it does so because of the sort of breadth and depth that we talked about in the last lecture that it provides, and it really incorporates a lot of the aspects of human sexuality in general, but is very inclusive of aging sexuality. So first I'm just going to go through some of the aspects of the biomedical model again. And as I mentioned in the last lecture, this is really the disease-focused model, a pathology one, the one that we're used to when we go to the doctor and they ask us what's wrong, right? What symptoms do you have? It's disease-focused, so this is where we get all of the sexual dysfunction diagnoses that we have in the Diagnostic and Statistical Manual, the DSM. For those of you not familiar with the DSM, that is just how we categorize all dysfunctions in mental health, and sexual dysfunctions are listed in there as well. Things like erectile dysfunction and dyspareunia, which is pain during sex, and dysfunctions of desire or interest. So that's where we get them from, and that really operates in a biomedical model. I'm going to look at your symptoms and diagnose which disease you have. And that, again, is from the Masters and Johnson, and they outlined the sexual response cycle, which was all about the bio, and it's a physiological response. So we get disorders or diseases when we look at each one of these different areas, whether it's desire, arousal, which is the excitement phase, plateau phase, which doesn't happen if you have premature ejaculation, so that's one dysfunction from that phase. The orgasm phase, which you can be anorgasmic or not able to achieve orgasm, so there's dysfunctions there, and the resolution phase. So you can see that these are the sexual response cycle for men and women, according to the biomedical model, is very similar, only that women can have the cycle multiple times as they are able to have multiple orgasms in one response. Able, not always able, right? Okay, so let's take a look back here. As I mentioned, it's all about the biological side, and it's a biological function that's subject to medicine or science, right? So all those things that we can measure and see and then prescribe some kind of treatment. The biomedical model really took flight for things like Viagra, right, which was a medication that came out in the 90s to be able to address erectile dysfunction in males. So I have a symptom, doc, I have a symptom, erectile dysfunction, patient, I have a pill, Viagra. That's a perfect biomedical model. However, that isn't the whole story. So even if you have erectile dysfunction and you get a pill and you can use it and it works for you, that doesn't mean that you have a holistic sense of sexual well-being. There's a lot more to the story, right? Which is the point of saying what's missing here in the biomedical model. So at the top part, we see the dysfunction focus. And I put the female saying ouch because female sexual pain or dyspareunia is one of the more common concerns that older adult women have. And that's partially because, as we see in the biological side, hormones, right? So estrogen decreases greatly after menopause, and estrogen is what helps you lubricate for sex. So when you're aroused, you lubricate, and that doesn't happen as much or very little when you're older, postmenopausal. So that can cause a lot of sexual pain. And for men, I have that it's almost there because erectile dysfunction is the most common sexual concern, oftentimes for older men. So as we saw in the last lecture, there were quite a few, around the high 30s or 40s and percents of men, older men, who report some kind of erectile dysfunction. Also in the biomedical model are the different biological functions, right? Or biological aspects of sexuality, which are included in the biopsychosocial model as well. Chronic diseases and the impact that they have on your sexual health, medications, hormones, as I mentioned, and sexually transmitted infections are a few. So it can do some things. The biomedical model isn't worthless. It's not, hasn't stuck around for no reason. It can help to treat certain things, to look at the very physical side of sex and help us to understand what's wrong when things are wrong on the biological side. But it is just biological. So what we need is something to balance that. And that's what we get with the biopsychosocial model. And the missing elements to these, right, on top of what we have in the biomedical model is the bio part, the blue circle. But we add that kind of coral circle and the psychological, and the yellow, deep yellow color with the social circle. So all of those three together are, and you can see sort of they all overlap, they all share with each other, but yet they have distinct areas that are their own. And this is a depiction of the biopsychosocial model. Let's look at some of the specific factors that go into those circles. Again, these are described in a lot more detail too in the Delamater and Sill article. And we're going to be going into each of these areas separately in different weeks. So for the individual components here, we have the biological, which we have detailed quite a bit in the biomedical model. But just as a review, that includes things like decreases or changes in hormones, estrogen and testosterone, which affect sexual desire a lot, or if you want to, if you physically are prompted to want to have sex. Medications and chronic disease, these two kind of go hand in hand. So things like heart disease is going to affect blood flow, which I mentioned last time, as well as diabetes affects your blood vessels a lot. So that means that your ability to have blood flowing to those sexual organs that need it for arousal and plateau phases and orgasm are going to be depleted if you have physical health problems like heart disease or diabetes. Also, the medications that you can take for certain diseases like blood pressure pills have sexual side effects. So as we're thinking about the typical older adult, a lot of times, especially the older that you get, you have some form of chronic disease, whether it's diabetes or heart disease or arthritis or have had cancer. You may not, but the likelihood is higher as you age to have a chronic disease that's going to affect your sexual health. In the biological side is also all the sexual dysfunctions, right? All the things that I talked about, erectile dysfunction, sexual pain, lack of lubrication, all of those are dysfunctions. Sexually transmitted infections, and all of the different activities or behaviors that are included in sexual behaviors, intercourse mostly on the biological side. Let's move over to the psychological side. In that, we see a lot of different things, and we're going to be talking a lot about the different types of attitudes and beliefs and things like sexual self-esteem, so we're going to dig deeper into those too. But for psychological factors, this is sort of stuff that's going on in your head, right? So what do I believe about sex? What are some of my attitudes towards it? Do I believe that sex is only for procreation, so once I'm postmenopausal, I can't do it anymore? Or some older adults may have internalized ageist beliefs that older adults are not supposed to be sexual, or that being sexual at an older age is dirty. So those types of things are included in the psychological, as well as your overall mental health, right? So depression, anxiety, those conditions are going to affect your sexual functioning as well, via just thoughts and apprehensions. And we'll talk a lot more about anxiety in particular in some of the later weeks as well. So sexual thoughts and fantasies fall under the psychological side. Sexual self-esteem is one that not a lot of people have heard of before, but it's basically the same thing as self-esteem, only just applied to your sexual self. So do you think that you are sexual, that you are effective sexually? Do you feel good about your sexuality? And that's kind of all encompassed in sexual self-esteem. I talked about internalized ageism, but also on the psychological side, it's that sort of spiritual connection or emotional connection that a lot of people feel or talk about when they have really satisfying sexual experiences, is feeling connected. Not always, and we're not always looking for a spiritual or deep connection, but that can be part of a lot of people's positive sexual experiences. On the social side of things, right, we have all of those interpersonal issues. One of the big things that I mentioned for older adults is just having a partner, right? What's your relationship status? Are you widowed? Are you single or divorced? Are you still married? Having a partner is a big part of the game in being sexual and having positive sexual experiences later in life. And not just having a partner, but what are they like? What's your quality of that relationship, right? So if I have a partner who's horrible to me, whom I dislike, or I'm afraid of, or constantly angry with, that's going to affect my ability to be intimate with that person. And also their health status. So not just your health, but your partner's health status. So if you're A-OK, don't have any health problems, but your partner is limited, that's going to affect that sexual script that I talked about, like the things that you do within your intimate behaviors that you can or allowed to do. It may be limited if your partner has problems. There are also, on the social side, is cultural issues. And we're going to talk about cultural frames and cultural ideas about sexuality next week as well. But that fits under the social side in that it's environmental, right? So your culture is your environment. How you grew up, where you grew up, the spiritual or religious contexts, the social context, what society says about sex and aging, which also is paired with ageism. But those cultural expectations about who can be sexual, what is right or wrong, those types of things. And there's also cultural norms. So if you would have said the word hooking up about 15 or 20 years ago, most people wouldn't have known what you're talking about. The activities existed, but they weren't called hooking up. So that's just one minor example of how cultural norms change, right? So we know that this sort of typical approach to sexuality has been a little bit more conservative in previous decades. So your parents and your parents' parents, if you think about the different generations and their experience of the cultural norms of sexuality, different types of behavior, different types of ways to talk about it, and even what, like I said, what is right or wrong. We think about even just in my parents' generation, their view of non-heterosexual individuals, LGBT individuals, and their sexual orientation and how that was not acceptable at all. So those are just a few of the things that we're going to talk about when we talk about the biopsychological and social sides of sexuality in a preview. But these are the big circles, right? Those big circles of areas that we talk about when we talk about sex. So this is a much more inclusive model, the biopsychosocial model, right? It's not just about what's wrong. There are those aspects in there, but it's also about what's right, your emotional, your social components, what you're experiencing, the things that you want, your values. They're all included in those three bigger circles. So it honors all those different aspects of sexuality. It also allows for a more flexible model of sexual responses. So remember back to the sexual response that we looked at for men and women. We have the excitement, the plateau, the orgasm, and the resolution phases. Well, that's a very linear look, and it's very performance outcome focused, right? Orgasm, and that's it. And how do I get there? And that's not a bad thing. That's a good experience for a lot of people to have. But for instance, when we think about the different ways that men and women approach sexuality or sexual situations and their response, this is a great model from Basson and colleagues. And this is more of a circular model where we talk about the female sexual response, which is more about and begins with and ends with kind of emotional intimacy or having a connection with another person versus necessarily that end performance-based outcome. And in this model, this is just an example of how the different biopsychosocial aspects can go together, having an emotional and physical satisfaction at the end, having those biological components of arousal and desire, but also appreciating and noting the psychological and social factors that go into that, like whether or not you seek out sexual stimuli or are receptive to them, or those are the ones that you are receptive to. So that's a lot about the psychological. And it also has a very connected relational social component. So this is just an example of the application of a biopsychosocial more model towards female sexuality. All right. So that's the biomedical versus biopsychosocial. And we can probably say goodbye to the biomedical model for now, because we're going to move squarely into the biopsychosocial model for the rest of the 8 weeks, although I may still trash on it every once in a while. But next time, we're going to be talking about cultural frames. So how we frame sexuality, how we look at it, those aspects of ageist beliefs and myths about sexuality and how that affects older adults, and the cultural norms, the things that we think of when we think of sex and how we are culturally defining that, and if older adults are in that picture and how they're in that picture. So that's for next time. For this week, make sure to do your reflection on the biomedical versus biopsychosocial model, and I'll be looking forward to reading all of your introductions and posting my own. So I'll see you next week.